Hi, my name is Anita Wallace, and I'm chair of the Lymphedema Support Network, and I'm delighted to introduce you to someone that I've worked with for, scarily, nearly 20 years. Professor Peter Mortimer. He's the LSN's Chief Medical Advisor and leading lymphedema specialist both here in the UK and overseas. The next question, I have to say, comes up within the LSN office on many occasions. And it's, does MLD help with lymphedema? And if it does, why is it not more readily available on the NHS?
Well, what a good question. First of all, and I'm dead against acronyms, but MLD is an accepted acronym which stands for Manual Lymphatic Drainage. And of course, it's very much part of lymphedema treatment. We have a lot of MLD and lymphedema therapists. And the principle of MLD is to open up and direct lymph drainage to areas which are not obstructed, where there is not a problem with lymph drainage. So it's designed to sort of redirect the lymph fluid from the swollen area to lymph gland areas which are draining normally. So if you take, for example, a breast cancer patient who's had their armpit lymph nodes removed, and so the main lymph drainage routes are not working very well, the MLD is designed to direct the lymph fluid out of the arm via collateral or escape routes where there is no obstruction. But those routes need a lot of encouragement. I use the analogy of saying you've got a block in the motorway and you've got to get all the motorway traffic now through the village roads. Well, that might need a lot of traffic control and direction and encouragement to make it work efficiently. That's basically what MLD is doing. Now, MLD is very skilled. It's a form of massage. It's very skilled and it's labor intensive. And in truth, the effect of MLD probably only lasts for hours or a day or so after it's done. So it's very limited and you have to then keep doing it if you want an effect from it. MLD is used best in a situation of acute treatment or intensive treatment, whereby you're using massage, exercise and bandaging to try and actually open up channels and get these collateral channels to drain. And MLD is probably best used in bite-size treatment periods rather than day after day after day, because that's really not sustainable logistically, cost-wise. I suppose the only exception to longer-term MLD would be where there's swelling of face, breast, genitalia, or what we call a midline lymphedema, where other treatments are very limited and MLD can work very well. But even then, it's probably not sustainable cost-wise. So the answer to the question is, why is it not more available on the NHS? We do use it on the NHS, but we use it for defined periods, intensive lymphedema treatment periods, where we think it's of most effect, and it's just not cost effective to use it long term.
Peter, when you talk about intensive periods, are you talking about if you require something like multi-layer lymphedema bandaging?
Yes, yes. The intensive, what's called decongestive lymphatic therapy or decongestive lymphedema therapy is a defined period of time, usually lasting 2 or 3 weeks, where you might have daily or alternate day treatment involving MLD and multi-layer lymphedema bandaging. And under those circumstances, the two complement each other, because the bandaging is sort of, with exercise, is, I say forcing, but pushing lymph upwards towards the root of an arm or a leg, for example, to drain it. But the MLD then is opening up the channels to allow it to escape more effectively when it reaches the root of the limb. So the two complement each other under those circumstances, and I think that's when MLD works the best.
Mm. Is it also true to say that there's more evidence-based research that MLD works within an intensive course of treatment rather than as a standalone top-up? That's what I've been led to believe.
Yes. I mean, many years ago, we did a study at the Royal Marsden looking at MLD alone and did find that it was effective. But the problem is it's quite difficult to measure improvements with MLD alone. So most of the studies actually use a combination of MLD and bandaging. And under those circumstances, you don't know which one's having the predominant effect. And to be fair, as I've said, because they complement each other, perhaps they both work better in combination than either used alone.
Yes, yes. Well, the feedback we often receive on the helpline is very mixed. For some people, top-up MLD they find very effective. For others, it just doesn't have any effect whatsoever.
Yes.
So, yeah, almost the jury's still out on that one, really.
Yes, but it is, because it's skilled and labour intensive. I mean, a session of MLD could easily be up to an hour. Well, that's expensive, and then you look at the question: is it cost effective? And that's where the NHS struggles.
Exactly. So, because it is so time consuming, because we all know about the funding restraints and the critical, state of the NHS, that's possibly another reason why it's so hard to get it in a top-up form on the NHS. Would you agree with that?
Absolutely. And that's why we try and copy it as best we can with what's called simple lymph drainage, which is essentially the patient or partner or carer, whoever it happens to be, trying to do a best copy of MLD. But of course, it's very difficult for effectively an untrained person to undertake a skilled procedure. But nevertheless, it's certainly better than not doing it.
Better than nothing,
So, and that's something that the patient can choose to keep going at no cost, really, except time.
Lovely. Thank you very much. Thank you.